this is Dr. Prats and welcome to my channel. So since last week we're discussing about odontogenic tumors, and today we are going to discuss a very important and a very aggressive tumor called ameloblastoma. Let's roll. So we follow the same format in every presentation. We start with what is the pathology, why do we need to study it, the three hows, that is how did it occur, how to diagnose by using your investigating tools like radiography and histopathology, and how to treat, especially in this case ameloblastoma is quite an aggressive tumor, and there are different types, so based on the type the treatment differs, followed by a summary of whatever we studied for the day. And of course, at the end, we will be discussing a multiple choice question and discussing the tips and tricks of how to answer it. Each lesson has to have an objective. So at the conclusion of this particular presentation, you will be able to define the tumor which we're going to discuss today, that is ameloblastoma, describe its etiopathogenesis, the features, that is clinical, radiographic, and histopathological features of each type of ameloblastoma, and the differential diagnosis of ameloblastoma. If you remember from the first series of odontogenic tumors, we had discussed about the classification of odontogenic tumors, where we said that the malignant variety will be discussed under the tumors itself. So we're going to see malignant ameloblastoma and its features in this presentation. And like I said, the treatment of ameloblastoma differs based on the type, so we're going to discuss that as well. Ameloblastoma is a tumor where the tumor cells form caricatures of enamel organ, and some of them resemble ameloblasts. However, they're incapable of making enamel matrix. So that is why they're called as ameloblast-like cells, and they're not actual ameloblasts, because if you remember from oral histology, ameloblasts are the cells which form enamel. There is a definition which is given by Robinson. He defined it as unicentric, intermittent in growth, anatomically benign, clinically persistent, and locally invasive tumor. So to remember this, I've just given you a mnemonic which I had used when I was a student to remember the definition. So that is UNIAC L. So UN stands for the unicentric, I for, of course, intermittent in growth, A for anatomically benign, C for clinically persistent, and L for locally invasive tumor. I hope that helps, students. Coming to the pathogenesis, it is very similar to the cystic pathogenesis, which we had discussed in our previous series. The link will be given in the description box below. So it is the cell rests or the cell remnants of dental lamina called as cell rests of Serre. And these are responsible for the tumors which occur within the bone or intra-bony tumors. There is also soft tissue tumor or the peripheral type. So that is caused by the cell rests of Melasses or the remnants of Hertwig's epithelial root sheath. This is a picture which shows how the cell rests are situated within the periodontium and other soft tissues around the tooth. And basal cells of the oral mucosa is another cause, and reduced enamel epithelium. I think I've discussed this as well in the series of the cysts, so I won't be going much in detail. So these are all similar etiopathogenesis. Another etiopathogenesis which we see in ameloblastoma or in case of odontogenic tumor is the wall of a cyst. If you remember, whenever we were discussing the potential complications under each cyst, especially dentigerous cyst, we said that it could turn into ameloblastoma. So the wall of cysts is another etiopathogenesis which is responsible for the development of ameloblastoma. So these we discussed, that is the enamel organ, the cellulus of Serae and cellulus of Melasses, basal cells of epithelium, and the epithelium of a cyst. So apart from these, there is gubernaculum dentis, which is nothing but a pathway for the permanent tooth to erupt. Usually, if you know, the permanent teeth kind of erupt lingual to the existing deciduous dentition, isn't it? So it's the gubernaculum dentis which guides the tooth along that pathway. There is an extragnathic type of ameloblastoma which is seen in the pituitary area, and this is called as Rathke's pouch tumor because Rathke's pouch is an extension of the oral ectoderm during the development, of course, and later this undergoes disintegration, but the remnants of that could result in an ameloblastoma-like tumor in the anterior lobe of pituitary. So that is called as craniopharyngioma or Rathke's pouch tumor. This is a very important question which they usually ask in the multiple choice questions as well as during your short essay and long essay questions. So you can see how big the tumor can grow and how aggressive it can get. So there are some genetic aspects which are explained. Various genes which are expressed during the odontogenesis or the tooth formation are normally dysregulated in case of ameloblastoma, and some experiments which were done in animals showed that ameloblastin, which is an enamel matrix protein, and ameloblast adhesion molecule were deleted, but this was not proven in humans, so we cannot really say it for sure. Also, several genes like matrix metalloproteinase, inducible nitric oxide synthase, and heat shock proteins were also seen, but they were all not considered the primary cause. So it is still unknown as to what's the primary cause of the tumor. Coming to the types of ameloblastoma, the first and most common type is the conventional type, which is also called as multicystic because it is essentially a solid tumor but with a lot of cystic spaces within it. So that's the most common type which we see. The second type is the unicystic type. So the name itself says that it is a single cystic space surrounding the tooth, and the peripheral is the one which occurs on the soft tissue. These both are intra-bony, whereas this is the soft tissue variant of ameloblastoma. So because the conventional type or the multicystic type is the most common, we'll start by discussing the features of that. So the clinical features which we see in this particular type is that it makes up for 11% of all odontogenic tumors. That is more common in case of males, and blacks are most commonly affected. Most of the studies are done in the Western countries, and that is why all your comparisons are between the blacks and whites. It's nothing else. And most of the patients, the age group is between 20 to 50, and usually the mean age of discovery is about 40 years of age. It can even occur in young children, which is quite sad. And it frequently appears as a rounded bony swelling in the posterior mandible normally. But there could be ulceration whenever the lesion has grown very big and it has perforated the cortex, then the surface appears ulcerated. Radiographically, it shows multilocular appearance, and multilocular can be described as soap bubble if the loculations are kind of small, whereas if the loculations are big, then it is referred to as honeycomb appearance. Buccal and lingual cortical expansion is also frequently present, and that can be also appreciated in the radiograph. So under histopathological features, the gross appears quite solid and it appears like a grayish yellow colored mass, and we see plenty of cystic spaces. If you can see here, there are many cystic spaces, which is nothing but the degeneration of the cells in those areas. So there are many variants of ameloblastoma histopathologically, but there is no real difference in the treatment aspect. It just makes your diagnosis more complicated and difficult, that is all. But it is essential that we know all the histopathological variants so that we can give a proper diagnosis and treat the patient in the right way, because ameloblastoma is quite an aggressive tumor. I've been saying that repeatedly. So this is a very common picture which we see in all the histopathological variants, no matter which type it is. So I'm going to say that so that you remember it forever. And then we're going to discuss the variants. So you remember the names of those variants and just the unique feature of that particular variant. Okay. This is actually one of the most common variants, which is called as a follicular variant, which appears like islands or nests, where the periphery is lined by ameloblast-like cells, and in the center we see stellate reticulum-like cells. So again, if you go back to your oral histology in the enamel organ, if you remember, ameloblast-like cells are nothing but the inner enamel epithelium, that is the columnar cells which become tall columnar, and the nuclei is situated away from the basement membrane and become active, and they start producing enamel, isn't it? So these cells resemble the same. They're tall columnar and the nuclei is away from the basement membrane, and that is called as ameloblast-like cells because they do not really produce any enamel matrix. And in the center, we see stellate reticulum-like cells. Again, in enamel organ, we have star-shaped network of cells, isn't it? That's why the name stellate reticulum. Stellate is star, and reticulum is network, a network of star-shaped cells. So this is going to be a common feature in all the variants. So let's see which are the variants. So the follicular type is the most easily recognizable type. Why? Because of the way it is arranged. It is arranged in the form of islands, or they're also called as nests, in a very loose connective tissue stroma. And the peripheral cells, of course, resemble the ameloblast. Here is a higher power micrograph of the same cells. So they're tall columnar with the nuclei away from the basement membrane. And in the center, we see stellate reticulum-like cells, or the star-shaped network of cells. The next variant is plexiform ameloblastoma. So here the cells are arranged as thin interlacing strands, if you can see here. Okay, so they're all interlacing strands, and the connective tissue is very less, and it is a loose connective tissue stroma. And the cells, if you notice, do not resemble ameloblasts at all. They're just simply small, darkly staining epithelial cells. Okay, so that's about plexiform ameloblastoma. And the next variant is called as acanthomatous type. So if you're seeing in the center, you can see that the cells have undergone squamous metaplasia. Yeah. And this could even produce some amount of keratin and even prickle cells. So this is called as acanthomatous for the same reason, because they've undergone squamous metaplasia. The next type is granular cell pattern. So what happens is the central areas of the tumor islands forms a lot of granular cells. This apparently is a result of degeneration of some of the cells in the center as well as in the periphery. So that results in the formation of eosinophilic granular structures, and hence the name granular cell pattern ameloblastoma. So the management essentially depends upon the size of the tumor and how close it is to the bone. If it is very small, then just excision is enough with some amount of peripheral bone. But if it is close to a bony margin, like you see here, you can see that there are islands of cells which are close to the bone. So in that scenario, we'll have to make sure that any extension into the surrounding bone is removed. And if it is really, really big, then hemimandibulectomy is the choice. As you can see here, half of the mandible has to be removed, and this has to be followed by bone grafting. So the next type is cystic ameloblastoma. So the name itself says cystic. So there is a single well-defined cavity which actually resembles a dentigerous cyst in over 80% of cases. And it occurs in the posterior mandible, and the age group is about second to third decade of life. And radiographically, you can see that it is associated with an impacted tooth, and there is a sclerotic border, and it is unilocular in appearance, it's not multilocular. Very similar appearance to dentigerous cyst again. And even histopathologically, the epithelium is often stretched and it loses its typical features. That is, you don't really see any ameloblast-like cells here if you see. Again, very close resemblance to the dentigerous cyst. But you will still see some islands which resemble an ameloblast, so that should help in the diagnosis. So there are several types of unicystic ameloblastoma as well. Luminal is when there is a single layer or single lining of epithelial cells around the lumen. And intraluminal is if there are any finger-like projections within the lumen, then it is called as intraluminal type. There is a mural type where you will see islands of ameloblastoma within the connective tissue wall. And this is considered as a unicystic ameloblastoma, not a conventional one. And of course, you have the solid multicystic ameloblastoma. So these two varieties, that is the luminal and intraluminal, can be enucleated, very similar to a cystic lesion. But if it is mural and if it is the multicystic ameloblastoma, then it requires excision along with some amount of surrounding bone. Differential diagnosis, I've kept saying dentigerous is the most common one, and the diagnosis of especially the unicystic ameloblastoma cannot be made until the biopsy is done. So you excise it, make a biopsy, and make sure it is a unicystic type of ameloblastoma. And you have to differentiate it from the dentigerous cyst by thorough investigation histopathologically. And that's when you consider it as a final treatment. Otherwise, you'll have to go ahead and do another aggressive treatment. The next differential diagnosis is squamous cell carcinoma. This is with the acanthomatous type. That could be confused with the squamous cell carcinoma, but we know that squamous cell carcinoma exhibits very typical epithelial dysplasia, which we will not see in case of acanthomatous ameloblastoma. It is just squamous-like cells, and there is some keratin formation. We'll not see any dysplasia. So that's how you differentiate it. Coming to the management, like I said, smaller lesions, enucleation, and cystic lesions are enucleation. And I've already explained this to you, that diagnosis can be made confidently only after removal because it requires detailed histological examination of the wall in case of unicystic ameloblastoma. Regular radiographic follow-up is very essential. So when the patient of ameloblastoma is coming to you and you're treating the patient, then you have to inform him or her that it is very essential that they come for a follow-up. There is a chance of recurrence and another operation might be necessary. So you warn the patient way ahead so that the patient does not complain later on. Peripheral ameloblastoma is seen on the soft tissue, and this is more common in the older age group. Some of the potential complications are the spread of ameloblastoma into the soft tissue. This is especially in case of maxillary tumors because the bone is quite thinner around it. It's not like mandible where we have very thick compact bones. So the spread to the orbit and cranium and brain is very easy when it is in case of maxilla. So we have to be very careful about it. So the malignant complication in case of ameloblastoma is called as ameloblastic carcinoma. So in some of the sections, we might not be able to differentiate it from any other carcinomas because the picture will be very, very similar. But on careful examination, you will see ameloblast-like cells in some of the sections, and that's when you will understand that it is an ameloblastic carcinoma. It might have started as a normal ameloblastoma, but then loses its differentiation and develops into a carcinoma later on. So the lymph node is the way of the spread, like most other carcinomas. The treatment is also similar to that of any other intraosseous carcinoma, but the prognosis is very poor, especially if the metastasis is present. If you remember, I told you in the beginning of this series that the death by cancer is not by the primary tumor at all. It's most of the cases, it is because of the metastasis, unless the primary tumor is present within brain or any other important organs. Other than that, the death is mainly by the metastasis. So I'm just summarizing the conventional type rather than the other types because this is the most common type. And it is the most common odontogenic neoplasm as well. Occurs between 30 to 50, especially at the age of 40, it is discovered. It is locally invasive but does not metastasize unless it becomes a carcinoma. It develops into a carcinoma. Usually asymptomatic and appears as multilocular radiolucency. Most commonly seen in the posterior mandible. If it is smaller lesion, then it is treated with excision with a margin of the normal bone. And if it is bigger, then in that case, you have to do hemimandibulectomy followed by some kind of a graft in that area. And one of the important complication is the spread of ameloblastoma into the soft tissue, and this is can be lethal in case of maxillary ameloblastoma because it could invade the cranial base and orbit and other important structures. So do not get overwhelmed, take a deep breath, and I've just summarized most of the features. That is the clinical radiography. Let me just quickly summarize the histopathology for you. So histopathologically, there are several variants, but there's no difference in the variant itself. So it just makes your diagnosis much more complicated, but it is still essential that you know all the types. The most common type is the follicular type, which is like islands of cells, followed by plexiform type, which is interconnected strands, but it does not show ameloblast-like cells because any nests or any other forms always show peripheral ameloblast-like cells and central stellate reticulum-like cells. This is the standard histopathological picture of an ameloblastoma. The next type is the acanthomatous type, where the central cells have undergone squamous metaplasia. This can be confused with the squamous cell carcinoma. And then there is granular cell pattern, where there is eosinophilic granules which are seen in the central part of the islands. So these are all different types of the conventional or multicystic pattern. In the unicystic pattern, there is luminal type, intraluminal type, and mural type. Luminal and intraluminal can be treated by simple excision. Enucleation, whereas the mural type has to be excised and treated similar to a multicystic pattern. The site which is considered lethal in case of ameloblastoma, is it mandibular ramus, is it angle of mandible, is it maxilla, is it body of the mandible? So I just now explained to you that soft tissue spread is a very potential complication of ameloblastoma. It could turn lethal, especially in case of maxilla, because the bone is thin and it could extend to orbit and brain and your cranium. If you liked my presentation today, and if you like the way I explain things, especially when it comes to MCQ, go to my website. The link will be given in the description box below. You will find plenty such MCQ in all the topics for you to practice. These are some of my references, and I hope it helped. If it has helped you, then please like it, subscribe to my channel, and share it with your friends. And comment below if you have any doubts. I will answer them. And if you like any other new topic which you find it hard and difficult to understand in oral pathology, just let me know and it will be on your way. Thank you and keep smiling.